Hello, am I audible? Hello. Yeah. Kindly log in through your own account. Actually, I think everyone has logged in through my account, through my joining link.
Hello everyone from Morocco.
Good evening, everyone. So thank you all of you for joining to my webinar. I would request all of you to rename uh, your Zoom ID. I think there has been mistake and the link whichever was shared was my personal one and all of you have uh, the same name. So requesting everyone to rename yourself. Hello. So I welcome all of you again to my webinar. So this is going to be a webinar series that is demystifying antibiotics. So I plan to do learn one antibiotic every fortnight, that is every 15 days. I'm extremely sorry for the last week, which I had to cancel because of my health issues. I had severe laryngitis, so I couldn't do the webinar. So without any further delay, let's start with it. I hope my screen is visible to all of you. Okay. So I request all of you to kindly be on mute, and I'll be happy to take the queries in the end. And if you have any queries, post it in the chat section. And there are going to be various polling questions. So please reply in the polls. And all the materials, including the slide set and the recording, will be shared. And as I have tried to make the presentation foolproof, but again, if there are any errors, please do excuse. And again, thank you all for joining the webinar. I hope this webinar will be useful for everyone. So this is my request to join this app, the Vivo app. Please join this app. So this is the Vivo app. So you can just scan the QR code, or you can just type vvox.app, and you have to input this 9-digit ID. So all of you, please join now. I'll give 2 minutes. I hope everyone will join, because all the polling questions would be based on this app. All of you, please, again reminding, please join this app. So you can just use any scanner in the by. So Paytm, Google, of the Google Pay. So I hope all of you have joined the joined this VWorks. So let's get started. So today we are going to discuss about carbapenem. So as I mentioned previously, I'm not going in an order like initial penicillin, cephalosporin. So why am I directly talking about carbapenems? I'm sure this is like one of the most abused antibiotic, misused and abused antibiotics, which is available at all institutes, and the most common antibiotic. So what are carbapenems? Carbapenems are important antibiotic in our antibiotic armamentarium, like one of the broadest spectrum antibiotics, which has against positive as well as gram-negative bacteria. So this is the introduction. So initially, the first carbapenem was introduced, which was imipenem, followed in 1985, followed by imipenem, and then meropenem, and scientifically, due to during the course of introduction of carbapenems, uh, the carbapenem is also started rising. That is various carbapenems, including KPC, NDM, OXA, etc. The most recent carbapenem which was introduced was doripenem. So carbapenems mainly can be classified into uh, 3 groups: Group 1, Group 2, as well as Group 3. I'm having some echo. I request all of you to please stay muted. Okay. So as I was saying, the carbapenems are classified into three main groups: Group 1, Group 2, and Group 3. And the Group 1 carbapenems include your ertapenem, whereas Group 2 includes your meropenem, imipenem, doripenem, etc. And Group 3 carbapenems are the carbapenems for development. So how they divided these carbapenems? So the Group 1 carbapenems have no activity against the non-fermenters, and Group 2 and Group 3 have activity. So that is a major difference between Group 1 and Group 2 and 3. And none of the carbapenems which are approved have activity against the MRSA. The Group 3, which is under development, that has even activity against the MRSA. So the 4 carbapenems which are approved include your imipenem, meropenem, ertapenem, and doripenem. Others which have recently been approved, that is in Japan, Thailand, and China, are the panipenem, tebipenem, and biapenem. So what are the properties of this carbapenem? They are active against broad. Broad range gram positives, gram negatives, aerobic as well as anaerobic. So they have high penetration to the bacterial outer membrane, and they have high affinity against multiple penicillin binding proteins, and they are active against many beta lactamases, including your class A, ESBL, as well as class C, that is your AIIMS. So coming to the chemistry, carbapenems are basically derivatives of thiamycin. So the two important groups which you should remember are the penems as well as carbapenem. They have a similar name, but they are not the same. So what are these carbapenems? So as I mentioned, they are the derivatives of thiamycin. That is, they have this 1-beta methyl group which confers resistance to renal hydrolysis by DHP, and they have this trans hydroxyethyl moiety which confers resistance to hydrolysis by the beta lactamases. So if you look at the same structure of various carbapenems, if you observe the imipenem, you can see there is no 1-beta methyl group. Hence, they have to be combined with cilastatin, which are DHP1 inhibitors. So the mechanism of action of carbapenem is same as that of any other beta lactam. So beta lactams bind to this transpeptidase site, and hence they will block this transpeptidase activity, and which interrupts the cross-linking and cell wall synthesis. So that was about the mechanism of action broadly about all of your carbapenem, including your uh, carbapenem. So this, what makes it different from other beta lactams? That is, it can bind to all types of penicillin binding proteins, including 1A, 1B, 2, 4, and hence this is what confers the broad spectrum activity. And they have different intensity of binding to penicillin binding protein, and this is what makes the spectrum slightly different between your meropenem, doripenem, as well as imipenem. So in the doripenem, the species-specific binding intensity is highest in case of Pseudomonas aeruginosa, and hence doripenem has highest activity against Pseudomonas aeruginosa in the carbapenems. So in gram-negative isolates, the bactericidal activity is greatest with 1A, 1B, and 2 rather than PBP3. So that is why carbapenems are more bactericidal and more broad spectrum than compared to the penicillins. Coming to the antibacterial spectrum, so it has broad spectrum. So it has gram-positive activity, gram-negative, bacilli as well as cocci. It has good activity against your anaerobes and other few special organisms. So in gram-positive, it has activity against your streptococcus, MSSA, cons, and enterococcus. But important thing to remember is it has no action against enterococcus, faecium, as well as MRSA. So carbapenems have no action against these two, and hence it should not be used when there is isolation of these organisms. In gram-negative, it has a very good activity against most of your Enterobacteriaceae. And as I mentioned, pseudo activity is maximum with doripenem, though your meropenem and the same has. One exception is etapenem has no activity against your non-fermenting gram-negative bacilli, that is Pseudomonas acinetobacter as well as Xenotrophomonas. Anaerobes, it has very good action against the anaerobes, and hence there is no necessity to add metronidazole when you're giving carbapenem, except for your C. diff, and it has also activity against nocardia except Farsinica and actinomyces. So coming to the pharmacology, when given parentally, it diffuses to most of your body tissues. So being broad spectrum and having good availability in most of the tissue is what makes carbapenem one of the most used antibiotic. It has good concentration in soft tissue, gynecological tissue, lungs, body fluids, peritoneal fluids, CSF. But it has no oral absorption. Why? Because it is acid level. So if you take it orally, it is broken by your stomach acid. And coming to the plasma protein, the maximum plasma protein binding is with the etapenem, that is more than 90%. So why is this plasma protein binding important? So this plasma protein binding means the drug will bind to the protein, and hence it will be available for longer duration of time for the action. And as it is one of the beta lactam, it is the PKPD parameter which is of importance is your time over the MIC, that is time dependent kinetics. It also has good post antibiotic effect. And coming to the T halves, most of them have 1R except for etapenem. Because of high plasma protein binding, it has longer plasma T half, that is more than 4 hours. And all of them are excreted to the renal, and hence in case of altered renal diseases, it has to be modified. Imipenem, as I mentioned, it has to be combined with cilastatin because of the absence of the DHP1. So this is a brief. So it has the TF of etapenem is around 4 hours with a good binding. Coming to the spectrum, as I mentioned, most of the carbapenem have the same spectrum. The exception is imipenem has a good gram-positive compared to others, whereas, as I mentioned, etapenem has less action on your Pseudomonas and your Acinetobacter. apart from that, all our carbapenems are almost equal. So as I mentioned, that all of them follow time-dependent kinetics, and hence the PKPD parameter is the time over the MIC, and preferably it should be available for more than 40% of the time. And it is mentioned, it is always better that all your beta lactams and as I mentioned, all the beta lactams have to be given as extended infusion. So this is required to tackle the MDROs and prevent emergence of the resistance. So if you can see this graph, so when you give the traditional dose, the time over which the MIC is staying for less time. Hence, it is required that you provide it as prolonged infusion so it can remain above the MIC for more than at least 40 to 50% of the total dosing frequency. So coming to the adverse effects, the most common nausea, vomiting, and because it is a broad spectrum agent, C. diphtheria is one of the side effects, and one of the common side effects which we all remember is the seizures. And why does this occur? Because these are structurally similar to the GABA and causing the antagonism. That is why there is higher propensity to the seizure potential is there in all the carbapenem, but it is maximum with your imipenem, and hence they have good CSF penetration. Imipenem and meropenem. Imipenem should be avoided in case of meningitis because of this seizure potential. And most of them do not have drug interaction, and hypersensitivity can occur rarely. And other side effect which you have to be concerned is the nephrotoxicity, neurotoxicity. So when we look at the FDA approval for various drugs, so meropenem has been approved for skin and soft tissue infection, intra-abdominal infection, and bacterial meningitis. Doripenem for intra-abdominal infection, UTI, and one important thing is the FDA has issued a black box warning of using doripenem against any type of pneumonia. So it should, though it has a very good pseudomonas coverage, it should not be using any type of pneumonia. Ertapenem and imipenem have a very, it has been approved for various indications. So if you can see, the meningitis which is approved only is your meropenem. So here I have a case scenario. So a 35-year-old female presented to emergency with complaints of fever for 3 days, burning micturition for 2 days associated with flank pain, urgency, and increased frequency. She is also a known case of type 2 diabetes for 10 years on OHA and hypertensive for 8 years and on antihypertensive. She is febrile. So in this, so what is your provisional diagnosis? I request all of you to use the polling option. So you can just look at your mobile. You would have got this poll. All of you, please respond. Please respond in the poll. Okay, let's end the poll here. So what is your provisional diagnosis? Okay, most of you have got it correct. Yes, it is a case of complicated UTI with pyelonephritis. The patient is having fever with flank pain, so it could be indicative of pyelonephritis, and it is a complicated UTI. So in this situation, what is the empiric antibiotic you would like to start? So please again use your poll. Please answer in the poll. Okay. Most of you have started on meropenem. So again, the empiric choice of antibiotic in a patient depends on many things. One, this is a complicated UTI with pyelonephritis. So obviously, definitely you have to give a IV antibiotic. And in a case of pyelonephritis, it is not recommended to use nitrofurantoin or cotrimoxazole. So those two options can be excluded. And further, ciprofloxacin resistance in India as well as all over the world is high. So you would better avoid the fluoroquinolones, that is a ciprofloxacin. And which one to use between ceftriaxone, piptaz, and meropenem depends on your local antibiogram. So it depends on what type of isolates which are common in the community techniques. So if your community is having less of ESBL, so you can still use ceftriaxone. But if the percentage of ESBL in your locality or in your hospital is more than 30%, you will have to go towards meropenem. So now, suppose in this case scenario, the ESBL rate was only 10%, and the patient was started on ceftriaxone. And after sending the urine culture and blood culture, now the urine culture report has come. So the urine culture report is showing E. coli more than 10 power 5, and with the sensitivity as shown. Now, what would you like to do? Whether you would like to continue the ceftriaxone, whether you'd like to stop ceftriaxone, start peptides, stop ceftriaxone and start cefepime, add amikacin, stop ceftriaxone, start meropenem, stop ceftriaxone and start ertapenem. So what would you like to do? Kindly use the polling. Okay, most of you couldn't respond, I guess. Stop ceftriaxone and start meropenem. Yes, that is the correct answer here in this situation, because if you have attended my previous webinar, you will be able to recognize the type of beta-lactamase produced in this. So the organism, the E. coli, is ceftriaxone resistant, which sensitive to your DLBLI as well as carbapenems. So this indicates this is a case of, it could be a case of ESBL producer. And in ESBL producer, it is recommended that the drug of choice should be initially be carbapenem. So, and starting the peptides in a ESBL patient, you can also consider that in a situation where the patient is hemodynamically stable and he or she is not having any source of infection. So, any other investigation you would like to do at this point? So, so I'm starting the poll now. What investigation would you like to do now? Continue only antibiotics, USG, KUB, CCT, abdomen and chest X-ray. Which investigation would you like to do? Okay. So most of you had yes. Doing the USG KUB. Yes, in any case of pyelonephritis, it is recommended at least to do the ultrasound KUB. Why? To rule out the type of pyelonephritis, whether there is any obstruction, or to find out if there is any renal abscess. So apart from the antibiotics, the important thing is the source control. CCT abdomen can also be done at a later time, but minimum investigation which is required is the USG KUB, and there is no indication of chest X-ray currently in this patient. So the patient improves slightly now and currently is not having any fever spike. The USG KUB which was done was suggestive of right pyelonephritis with renal abscess. So what would you like to do next? In this, there are multiple options which you can choose. So I will start the polling now. I hope all of you respond there. So continue only antibiotic, urology opinion for draining, add amikacin, provide antibiotic, a dual antibiotic cover for the abscess, and add metronidazole. So what would you like to do now? Okay. Yes. Any abscesses has to be drained. And I'm very happy that none of you chose add amikacin. As I mentioned in my previous webinar, amikacin has no action in abscesses, and there is no requirement of dual antibiotic cover. So basically, the important thing in any disease or the infection is source control. Source control is the first and most paramount importance, because unless the source is removed, how much ever antibiotics, multiple antibiotics you pump in, there won't be any action. And there, as I mentioned, there is no requirement to add metronidazole because carbapenem has good anaerobic coverage. And obviously, you'll be continuing the antibiotic, but you have to get the abscess drained. So now the abscess has been drained and patient has improved and is afebrile, vitally stable. Repeat cultures have been sent and both blood and urine cultures are sterile. So what would you like to do next? Whether you would like to continue IV meropenem, give OPAT IV etapenem, switch to peptides, repeat USG and confirm no collection, discharge the patient on tablet nitrofurantoin. So again, this is a multiple choice question. It can be multiple options which are correct. So I'll be starting the poll now. So I hope all of you will respond there. So okay. Yes. One thing, first major important point is you have to repeat the USG and confirm that there is no collection. And now the patient has improved completely and hemodynamically stable and he is afebrile. You can do the de-escalation. So which antibiotic you would like to de-escalate to, either IV etapenem, IV peptides or nitrofurantoin? Again, I would like to emphasize here that pyelonephritis never discharge a patient on nitrofurantoin. You will have to give IV antibiotic, and you can, in this situation, if the patient is willing for discharge, you can discharge on IV etapenem. If the patient is going to stay with you, you can de-escalate to your BLBLI. So this is one of the indication where you can de-escalate to the BLBLI after the source is drained or the source is controlled. The patient is hemodynamically stable and the repeat cultures are sterile and showing sensitivity to the agent. So you can de-escalate to your BLBLI as well. So what is the duration of treatment you will be giving? This is a case of pyelonephritis with renal abscess. Again, the usual recommended time is 10 to 14 days, but there are emerging studies which suggest that shorter courses of antibiotic, that is 10 to 7, up to 7 to 10 days, can also be given depending upon the patient's response. So let's just have a look at the chat sheet. Okay. Most of you have responded in this here. So are all carbapenems the same? Let's have a look at it. So the similarities, as I mentioned, all of the carbapenems are broad spectrum. They have good anaerobic activity, except that of C. difficile. Hence, there is no need to add metronidazole. They have no action on MRSA and Enterococcus faecium, and they are active against ESBL and AIIMS. That is, they are the drug of choice for ESBLs and AIIMS producer, and all of them are intrinsically resistant to Stenotrophomonas maltophilia, Elizabeth Kingia meningoseptica, and Tisiobacterium. And apart from this, imipenem, meropenem, doripenem are therapeutically equivalent in most of the clinical situation and can be used interchangeably. So what are the differences between them then? So in the Coming to the gram-positive coverage, your imipenem and doripenem are slightly more potent than the ertapenem and meropenem. And as I've mentioned before, and I would like to emphasize, they have no activity against the Enterococcus faecium. Coming to Pseudomonas aeruginosa, as I mentioned, doripenem is the most potent antibiotic against the Pseudomonas aeruginosa, and ertapenem should not be used in cases of Pseudomonas aeruginosa. Acinetobacter, carbapenems are considered the drug of choice for treating serious infections caused by Leishmaniasis, and imipenem has a slightly better action on Acinetobacter compared to your meropenem. And again, again to emphasize, ertapenem should not be used in cases of Acinetobacter. So when to use which which carbapenem is always a confusion. Let me try to simplify it. So in ages less than 3 months, available as per the FDA. When can you use doripenem? Doripenem is approved only above 18 years, and again I have to emphasize that it should not be used in any cases of pneumonia, community-acquired pneumonia or OPAT, which is the carbapenem of choice, that is your ertapenem, because of high TRs. Nosocomial pneumonia, imipenem and meropenem. Imipenem is slightly better because of the good Acinetobacter coverage. So what is the drug of choice for ESBL, AMC, VAP, severe sepsis, polymicrobial infection? Meropenem, imipenem can be used equally. Meningitis, meropenem remains the carbapenem of choice. Imipenem, as I mentioned, it also has good penetration. But imipenem, because of the seizure potential, it is better to avoid in patients with meningitis. So in intra-abdominal infection, imipenem, because of a better gram-positive coverage, can be considered over meropenem. UTI, imipenem and meropenem, because this is, as I mentioned, showed before, if meropenem is not FDA approved for the UTI. Skin and soft tissue infection, you would look for more of gram-positive coverage, hence imipenem has slightly better edge over meropenem. And which of the carbapenem has lowest AMR potential? That is doripenem, followed by your meropenem. What is the drug of choice in cases of melioidosis? Meropenem or imipenem can be used. Febrile neutropenia, imipenem is preferred over meropenem. And whenever situation is there and you have the culture report demonstrating and non-fermenting, which is enterobacterial, and it is not Pseudomonas or ertapenem, always de-escalate to an ertapenem. And that is once the sensitivity is demonstrated. So a note on oral carbapenem. So I had given a pre-webinar questionnaire, where one of the questions which I have asked is, which of the following is an oral carbapenem? Is it Faropenem? No. Your Faropenem does not belong to the class of carbapenem. So I will be discussing it slightly in the next part of my session. So let's talk about oral carbapenem. Because the carbapenems are acid labiles, most of the approved carbapenems cannot be given orally. So tebipenem pivoxil is one of the world's first oral carbapenem, and it was developed in Japan, and it has the same activity or the spectrum as that of your carbapenem, and they do not have activity against your MRSA as well as Pseudomonas aeruginosa. So let's just recapitulate what we have learned till now. So which of the drug is to be avoided in patients with seizures? Your imipenem. Which is the best against Pseudomonas? Your doripenem. Which has no activity, which carbapenem has no activity against pseudo, acinate or entero? That is your ertapenem. And what type of kinetics or PK parameters is exhibited by the carbapenem is time dependent. Is activated against Enterococcus faecium? None. So this is one of the points. So Enterococcus faecium, none of your carbapenem is active. Which is the oral carbapenem? It is your tebipenem. And which is the most protein-bound carbapenem? That is your ertapenem. And hence, once a day dosing is permissible. So now let's talk about briefly about your penem group. So what are these penems? So the only drug in the penem group is your Faropenem, and again to emphasize, it is not a carbapenem, and this has a good oral bioavailability. And this Faropenem is one of the drug which is only approved in India. It is not approved by the FDA. It has a DCGL approval, and it was approved in 2010. And just between 2010 to 2014, the consumption of Faropenem has increased more than 150%, and this is assuming that it has the same coverage as that of your Carbapenem. Though it is not well studied against ESBL, it is widely marketed for the same, that is, it has good activity against the ESBL and is equivalent to Carbapenem. That is how it is marketed, and it is different. As I am shown before, the Carbapenem and the Penem group are different. It differs in the sulfur position in this one, which differentiates it from the Carbapenem, and it has no action against your Pseudomonas aeruginosa, MRSA, Acinetobacter, Steno, or Enterococcus faecium. So why Faropenem should not be used more? It is the first thing is there's inappropriate use for the indication which it is not approved for. As I mentioned, there are no studies which is suggestive quite very effective efficacy against the ESBL, but it is widely used for the same, and this is a lack of oversight of the off-label use, that is for other clinical indication apart from what it has been approved for. And what is the important thing is, because of there is high risk of development of process resistant to Carbapenem and suboptimal dosing, leading to higher increase in rate of Carbapenem resistant bacteria. And there are no breakpoints which is available, so we can't even track the development of resistance. And there are actually two formulations of Faropenem which is available, and sadly, the formulation which is available in India, that is Faropenem sodium, is poorly observed and has a very low bioavailability. And FDA, after repeated application for the approval, it has rejected the use of Faropenem, and hence I request all of you not to use Faropenem as equivalent to oral Carbapenem. So coming to the Carbapenem resistance, so as I mentioned, it is intrinsically resistant to Xenotrophomonas, Elizabeth kingia, as well as Faeciobacterium. And the resistance is mainly by three major mechanisms. That is by beta-lactamase production, that is Carbapenemase, reduce permeability by either chlorine channels or the efflux of the drug, or alter target binding. So these are the carbapenesis classes, class A, B, and D, which I have already discussed in my previous webinar. So class A consists of a KPC, SME, IME, etc. Class B consists of IMP, VIM, NDM, that is your metallo-beta-lactamases. Class D consists of your OXA carbapenemases or OXA beta-lactamase. So I'm sure most of you would have seen the culture reports, and there will be varied reports like imipenem resistant but sensitive to meropenem, imipenem, doripenem, etc. This discordance of carbapenem susceptibility are a reality, and hence it is required that each and every agent is tested individually, because they will denote different mechanism of resistance. So these are various breakpoints which are available for a Carbapenem, which is available in the CLSI for Enterobacterial, Pseudomonas, as well as Acinetobacter. As I have mentioned, Ertapenem will not be available for Pseudomonas and Acinetobacter because they do not have any action. So here I have a case. A 19-year-old male in the ICU, initially admitted for trauma, develops VAP, has a rapid augmented creatinine clearance of 140 ml per minute. He has isolated Klebsiella more than 10^5 in the ball. So this is the MIC report showing Miro, which has a MIC of 2, indicating intermediate sensitivity, imipenem intermediate, Piptas is resistant, amikacin resistant, as well as Cipro resistance. So what would you like to do in this situation? So again, this is a polling question. Please answer whether you would like to stop the meropenem and start colistin, stop meropenem, start ceftazidime avibactam as it is Klebsiella, continue meropenem at the same dose, continue meropenem at a different dose. I'll be starting the poll now. Okay, this is a mixed response. Again, I agree. The meropenem is intermediate here, not resistant. Okay, so whether you would like to go to colistin, whether you can start, you are required to start ceftazidime, continue meropenem. Let's have a look at the same. So whenever a drug is having intermediate sensitivity, it doesn't necessarily mean resistance. That is one of the important point. Another thing is when you have the so let's try to understand the MIC. So if the meropenem MIC is 0.5, that means it is sensitive. You can achieve this by giving 1 gram IV every 8 hours. So if the MIC is 2, that is in the intermediate range, then you can achieve by giving achieve the PKPD parameter by giving 2 gram IV dose every 8 hours. So instead of giving a higher dose, if you give a prolonged infusion that is over 3 hours, you can achieve the MIC time over the MIC by giving a lower dose of 1 gram every 8 hours. So for dose optimization, what you can do? So whenever a drug is having intermediate sensitivity, you can overcome that by giving a higher dose. That is, instead of usual 1 gram, you can give 2 gram, or you can give more frequent doses. Instead of 8 hourly, you can give every 6 hourly, or you can give prolonged infusion. That is, instead of 30-minute infusion, you can give prolonged infusion of over 3 hours. So one of this you can use to overcome this intermediate susceptibility. And again, carbapenems testing is one of the important things. So nowadays there are various tests which are done. Before there was modified Hodge test which was used, and there are newer methods which have been developed, that's Carbapenem and variants, etc. Due to the these are not under the scope of my discussion today, so I'll not be discussing in detail the mechanism or the of all these tests. The important thing here is there are nowadays lateral flow tests which are available for detecting carbapenems testing, which can give directly the type of carbapenems from the direct culture broth within 20 to 30 minutes. So this is the Carba5 test, or the score is bioconcept OKNIV test, resist OKNIV test, which can be used for detecting the type of carbapenems. And even we have a Carba R gene expert, which can detect KPC, NDM, WIM, IM, or OXA type of carbapenems. And the difference, as I mentioned before, there can be difference in susceptibility of the various carbapenems, and that can be used as a pointer to detect the type of resistance. So this can be used as a method to find out the physical mechanism of resistance. So in case of enterobacterial, to find out if it is a non-carbapenems mediated. So if the organism is showing resistance only to ertapenem with AIIMS or ESBL activity, then you can suspect it could be a non-carbapenems producer. For Pseudomonas aeruginosa, carbapenems production is not one of the major mechanism of resistance to carbapenem in Pseudomonas. So you can see, you would have seen multiple reports where it would have been showing resistance to carbapenem, but sensitive to other beta-lactams, including your piptaz, ceftazidime, etc. So that is because it is mediated by other mechanisms like your Corin loss or efflux. So summarizing, so Ertapenem, as I mentioned, it has no activity against Pseudomonas or Acinetobacter, and it has a high TRF, so it can be used as a once a daily dosing, and it is the drug of choice for community acquired and never for nosocomial infection, and it is the drug of choice for OPAT regimen. Imipenem cilastatin, it has good CSF penetration, but it is not used in CNS patients because of the higher propensity to cause seizures, and there is no activity against MRSA. And Meropenem, again, it is the only carbapenem which is FDA approved for meningitis, and the unique application is it has a good activity even against tuberculosis bacteria. Hence, it is one of the drugs in the MDR regimen. Dolipenem, as I mentioned, it is the most active against your Pseudomonas. And as I mentioned, black box warning, and hence it should not be used in any cases of pneumonia. And it is approved only for ages 18 and above. So, ending. So these are my take-home messages. That is that carbapenem remains to be the drug of choice for your ESBL and AMC. And you can use it as empiric whenever you're suspecting high inoculum infection and the patient is in severe sepsis or shock. And it is important that you administer all your beta-lactams and carbapenem as extended infusion over 3 hours. And always have to know your local antibiotic to prescribe the empiric antibiotic. So these are my references. Thank you. So I'll be happy to take any questions now.
Hello, Akshatha.
Yes.
Yeah, what is the, can we give these carbapenems as a continuous infusion for 24 hours? There are some studies which are coming up that you can give for the 24 hours rather than using an infusion for 3 hours. So can we give it for a continuous infusion for 24 hours? Is it,
Yes.
more
Beta-lactams
beneficial?
you can give as prolonged infusion as well as continuous. Continuous, you have to give the entire dose. You will have to you have to put it in the wire, this one saline board, and then that can be given as a continuous infusion as well.
But there is no any issue of stability of the carbapenems.
Stability,
for 24 hours.
it has been approved. I am having this echo. Okay, let's look at the chat section.
Ma'am, I am Dr. Mohammed Hassan. I want to ask this question. What should be the option for the Indian resistance? Could you, ma'am, highlight this topic as well?
Can you repeat? Sorry, I am having some echo. So please repeat the question.
Ma'am, what should be the option for the NDM resistance?
NDM resistance?
People are facing this issue because people, I think this is not issue in the European countries, not in the US, because we people are facing this issue in the Asian people have this issue. What should be the option for this kind of resistance?
NDM resistance, currently we have ceftazidime avibactam with aztreonam. So that is the drug which we use. Colistin we try to restrict. So we can do the synergy test, and if it is positive, so you can use ceftazidime avibactam with aztreonam together.
Ma'am, aztreonam should be used separately. Aztreonam should be used alone or should be combined in other drugs?
There's one doubt. So in Merino trial, they generally say that if it's an ESBL, you go in for beta lactam if it's the patient is hemodynamically stable. So I just, if you could clarify again where we can use BLBLIs in ESBL cases and where we cannot. That.
Okay, this point I have made clear in my previous webinar. This is one of the important point. IDSA, because of the Merino trial, IDSA strongly recommends that you don't start any BLBLI in cases of ESBL. But during further AMR 1.1, they have modified that one, and they have said that you can give PIP test once the source control is achieved. There is demonstrated susceptibility as well as the patient is hemodynamically stable. In that situation, you can give BLBLI as well, especially in situation like UTI. It is you can easily give your BLBLI.
Okay, so only when there is a pyelonephritis or any any source control required, only in those cases we have to restrict them.
Yes.
Okay. What about if we get CAPD fluid and again if you have grown E. coli with an ESBL or in cases of post renal transplant and any carcinoma of the bladder. So what do we do for all these situations? Patient is hemodynamically stable in all these conditions, but.
So the patient is hemodynamically stable, and if there is not very high source of infection, then you can still give PIP test. But in our institute, we prefer Carbapenem over the PIP test because we have not seen good improvement in the patient who are put on PIP test, or there will be some initial improvement followed by later worsening.
Okay, thanks a lot, ma'am. Thanks for clearing.
Yeah. Okay, if there are, let me look at this one. Main mechanism of resistance of Pseudomonas, it differs from place to place. In few of the studies, they have mentioned Carbapenems, but again, the major mechanism remains to be Corin as well as Efflex, not predominantly Carbapenems. So enterococcus. So once you have isolated enterococcus, you will be not giving your carbapenem. You will have to give based on the sensitivity. If you are trying to cover broadly, you can give any of the carbapenem for your except your etapenem in that situation. All the slides and the resource materials will be shared, and I'll be sharing the feedback link. I would request all of you to respond to that. Okay. Thank you everyone for joining. I'll be ending the meeting now.